Hello friends and welcome to my YouTube channel. In today's video, we will study about the Surviving Sepsis campaign. Without any delay, let's get started. Sepsis is any life-threatening organ dysfunction caused by dysregulated host response to infection. Septic shock. It is a subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. Pathophysiology of sepsis. Whenever a body is infected with bacterial endotoxin, there is widespread leukocyte activation and massive cytokine release. All this leads to diffuse cerebral dysfunction, increased leukocyte oxygen consumption, febrile response, increased whole body metabolic rate, acute lung injury, vasodilation and increased permeability, impaired cardiac contractility, decreased renal function, widespread complement and coagulation activation, and poor hepatic synthetic function. Now, this increased oxygen consumption and increased whole body metabolic rate and lung injury will lead to a hypoxic respiratory failure. Vasodilation, increased permeability, and impaired cardiac contractility will lead to a hemodynamic collapse. And decreased renal function and widespread complement cascade activation will lead to acute renal failure, disseminated intravascular coagulation, and coagulopathy. For the diagnosis of sepsis, we use the SOFA score, which is sequential or sepsis-related organ failure assessment score. It scores the patient on the basis of PF ratio, platelet count, serum bilirubin, cardiovascular parameters like mean arterial pressure, Glasgow Coma Scale, creatinine, and urine output. The 1 hour bundle. As soon as you receive a patient of sepsis, the following has to be done within 1 hour of receiving the patient. Number 1. Measure lactate level and remeasure if initial lactate is more than 2 millimoles of liter after 3 hours. Obtain cultures prior to administration of antibiotics. Administer broad spectrum antibiotics. Begin rapid administration of 30 ml per kg crystalloid for hypotension or if lactate is more than 4 millimeters per liter. Apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of more than 65 mm of Hg. A rapid SOFA score can be used for a quick reassessment of the patient, where a patient is given each point for altered mental status, which is GCS less than 15, tachypnea, that is respiratory rate more than 22, and hypertension, that is SPP less than 100. A patient with 0 or 1 points is not at high risk of sepsis, whereas a patient with 2 or 3 points is at higher risk for sepsis. For a patient with sepsis, these are the following recommendations. There should be early administration of antibiotics. Only colloids and crystalloids should be given. Starches and high chloride fluids should be avoided. Goal-oriented therapy should not be given while giving fluid initially. Early goal-directed therapy should again be avoided. Urinary catheter should be inserted. Lung protective ventilation should be given, keeping in mind that patient can go into ARDS. Deep sedation should be avoided. Vasopressors like norepinephrine, epinephrine, and vasopressin only have to be used. Dopamine and phenylephrine are contraindicated. Enteral feeding should be started, and insulin therapy should be given if blood sugar levels are high. Now, for application of fluid resuscitation in a septic shock patient, when the patient comes to you, see if the patient has sepsis-induced hypertension or if the lactate is more than 4. Now, if any of this is present and patient is not on high flow oxygen and is not on dialysis or CHF, then you can give 30 ml per kg of crystalloid. The patient has clinical features of pneumonia or acute lung injury with high flow oxygen requirements, then you have to intubate the patient and mechanically ventilate the patient and still give him 30 ml per kg crystalloid. And if the patient is on hemodialysis or has congestive heart failure, still you have to give 30 ml per kg crystalloid, but you have to frequently assess the patient for oxygenation. And if you find that the oxygenation is inadequate, then you can ventilate the patient. Now, regarding vasopressor use for adult septic shock. If the mean arterial pressure in the patient is continuously 65 or less mm of Hg, despite giving fluid resuscitation, first you have to start norepinephrine and titrate it up to 35 to 90 mics per minute. If the mean arterial pressure is achieved, then norepinephrine can be tapered and can be replaced by vasopressin. But if it is not achieved, then you have to add vasopressin in addition to norepinephrine. The dose of vasopressin is up to 0.03 units per minute. If still the mean arterial pressure target is not achieved, then you can add epinephrine at a dose of 20 to 50 micrograms per minute. And if still it is not achieved, then phenylephrine can be added up to 200 to 300 microgram per minute. So this was all about sepsis and septic shock. I hope this presentation was useful to you. If you liked the video, please subscribe to our channel and share the video with others so that they can benefit from this knowledge. Thank you.